Okay, go ahead.
So we're right here, we're presenting esophageal cancer for pathophysiology class for Azusa Pacific University. I have Alan Danielle De Leon, myself, Justin Fenton, Susanna Manukan, Wailing Sun, and we're here to present the esophageal cancer for you.
All right, I'm going to start with the etiology of esophageal cancer. And there are two reasons, caused by the inherited gene mutations. Another is acquired gene mutations. And a very small number of esophageal cancers are caused by inherited gene mutations. In most cases of esophageal cancer, acquired during people's life rather than having been inherited. So here are four gene mutations due to the inherited. First one is pilosis with esophageal cancer. Inherited changes in the RHBDF2 gene. People with the changes in this gene are more at risk of developing the squamous cell type of esophageal cancer, and the Bloom syndrome caused by changes in the BLM gene, which is important in making a protein that stabilizes DNA as a cell divides. The DNA can become damaged without this protein. People with the Bloom syndromes are at a higher risk of developing squamous cell esophageal cancer. Fanconi anemia. It cannot compare damaged DNA. Mutations in certain genes can lead to a higher risk of many cancers, including AML and the squamous cell cancer of the esophagus. Familial Barrett esophagus is a syndrome that includes families with Barrett's esophagus and adenocarcinoma of the esophagus and the GE junction. It is usually found in people who have a long-standing chronic acid reflux and occurs in 6% to 14% of people with chronic GERD. And sure, it's acquired gene. We mentioned that it's the most reason cause the esophageal cancer. But certain risk factors such as tobacco and alcohol use probably plays a role in causing these acquired mutations. But so far, it's not known what causes most of them. The incidence and prevalence of esophageal cancer is more common among men than among women. The lifetime risk of esophageal cancer in the United States is about 1 in 125 in men and about 1 in 417 in women. Overall, the rates of esophageal cancer in the United States have been fairly stable for many years, but over the past decade, they have been decreasing slightly. It is most common in whites. Adenocarcinoma is the most common type of cancer of the esophagus. Among whites, while squamous cell carcinoma is more common in African American, Indian, Alaska Natives, and the Hispanics have a lower rate of esophageal cancer, followed by Asian Pacific Islanders. And the esophageal cancer makes up about 1% of all cancers diagnosed in the United States, but it is much more common in some other parts of the world, such as Iran, northern China, India, and southern Africa. And nowadays, about 20% of patients survive at least 5 years after diagnosis.
So
Here.
for differential diagnosis for the esophageal cancer, according to an article by Masab, there are a few differential diagnoses, which can include achalasia, esophageoleiomyoma, esophageal stricture, gastric cancer, and the pathophysiology of it is, according to Huether and authors, the carcinoma of the esophagus includes squamous cell carcinoma and adenocarcinoma, which is more prevalent in the United States among other countries. Squamous, more common in cervical and thoracic region. There's a big link between alcohol and tobacco smoking. Adenocarcinoma is linked between obesity, tobacco smoke, and GERD. The mucosal lining becomes similar in the intestine texture called Barrett's esophagus. Then there's the gastric carcinoma may invade this region, causing a adenocarcinoma too.
Signs and symptoms of esophageal cancer. The most common types of esophageal cancer are adenocarcinoma and squamous cell carcinoma. Those two types of cancers tend to develop in different parts of esophagus and are driven by different genetic changes. Signs and symptoms are trouble swallowing, unintentional weight loss, chest pain, worsening indigestion or heartburn, coughing, and hoarseness. Diagnostics. Diagnostic tests may include barium swallow X-ray, in which patient drink a liquid that coats esophagus so doctor will identify problem areas. Endoscopy. Endoscopic ultrasounds uses sound waves to provide more information about the extent of tumor involvement. Biopsy. During endoscopy, doctor may remove a small tissue sample with needle for further evaluation of cancer cells. Computerized tomography or esophagus to identify location, size, and stage of cancer. Positron emission tomography. They use radioactive substance. It is a technique that measures physiological function by looking at blood flow, metabolism, and neurotransmitters. Thoracoscopy and laparoscopy may perform to determine if the cancer had spread and metastasized. This process called staging. After determining the stage, the doctors are starting the treatment. Stage 0, surgery, photodynamic therapy, radiotherapy, ablation, or endoscopic mucosal resection, which uses a device that targets cancer cells with radiofrequency energy. Stage 1, 2, and 3, mostly surgery, part or all the esophagus may be removed. Chemotherapy, radiation, photodynamic therapy, which targets cells, cancer cells with special laser light. Electrocoagulation, which uses electric current to destroy cancer cells. Also, they use cryotherapy, which freezes cancer cells to help shrink a tumor. Stage 4. Still, we use chemotherapy, radiation-targeted therapy, immunotherapy. For this stage, doctors also focuses on palliative therapy and pain management. In addition, all those treatments, doctors may also recommend to participate patients in clinical trials. And
All right, so our prognosis, patient's prognosis with esophageal cancer depends on malignancy of the cancer, and if it did not spread beyond sites, the cure is possible for a patient. But if it metastasized and in incomplete resection is of little survival benefit, patient will need to be diagnosed and examined for neoplastic change by use of, like Susanna says, the treatments like endoscopic, ultrasound, and CT studies. Also, prognosis depends by removal of high-grade dysplasia to manage Barrett syndrome, Barrett esophagus, and when lymph nodes with tumor removed, which can be beneficial for the patient. Esophageal cancer metastasizes rapidly. Patient can possibly have poor prognosis. Patient will need to have combined radiation and chemotherapy for better prognosis. Next slide, please. Our nursing care plan, our priority is acute pain related to esophageal carcinoma as evidenced by patient report of constant retrosternal pain that radiates to the back. Our goal for this patient is patient will report decreased or no pain by the end of my shift. Our intervention is first to assess pain history, PQRST, and ask patient and no verbal rating like 0 out of 10. Can you go back, please? Also, we have to administer analgesics per doctor order and evaluate pain relief and control at regular intervals. Next slide, please. Thank you. So second priority would be impaired swallowing due to development of adenocarcinoma on thoracic and cervical area of esophagus, secondary to esophageal cancer, as evidenced by difficulty swallowing. So our goal for this patient is patient will not experience aspiration of food or fluid by the end of my shift. First, we have to assess patient's ability to swallow by asking patient to swallow or to cough and test gag reflex. Number two in nursing intervention is if patient has difficulty swallowing, do not feed until appropriate diagnostic workup is completed, maybe a speech pathology consult. And these are our references from our research regarding esophageal cancer. Thank you for listening.
okay.
And
Sorry, give me a second.